Okay, we're just going to give one more minute just to make sure that everybody's able to join us, and then we'll start. Thank you very much, everybody, for coming to our session. I think we'll start with the introductions, just to give that couple of minutes or that 30 seconds for people to sort of join us. So I'm Dr. Andres Fonseca. I'm a consultant psychiatrist, and I am a CEO and co-founder of Thrive. And with me today is Elisa. Elisa, did you want to introduce yourself?
Yeah. Hi, everyone. Thanks for joining us. I'm Elisa, and I'm a business psychologist at Thrive.
And what we're going to do, the session should take us about 45 minutes or so, and then 50 minutes for questions. But there's a Q&A function that some of you have discovered already. And the idea is that, just throw out any questions. Elisa is going to be monitoring that and monitoring the chat, just in case there's anything. And she will come, interrupt me and ask me any questions if it's relevant to whatever topic I'm talking about at the moment. So just feel free to sort of be asking questions as we go along. But there will be time at the end as well for questions. So there's a Q&A function there, and there's also a chat function, and you can chat to. If you send me any message, I probably won't see them because I will be focused on the seminar itself. But you can send anything to Elisa, and she will bring it to my attention if necessary. So, okay, so thank you very much. So what I wanted to talk about today. Let me see if this is working. Yeah. So this is the topics that I want to cover. So it's an overview in which I make particular emphasis on the possible links between the menopause and mental health conditions such as depression and anxiety. But we also discuss the management of the symptoms of the menopause in general, paying attention to both the use of hormones and other medication as well. And also I discuss interventions that do not use any medication at all. So I think what I'd like to focus on is, just exactly what is the menopause as the first question. So it's a phenomenon whereby a woman who has menstrual periods stops having them for at least 12 months. And this is as a result of the changes in a range of reproductive hormones. And I've got some key hormones up there that are the ones that particularly change during this period of time. So there's the anti-Mullerian hormone, the follicle stimulating hormone, inhibin B, and estradiol. So hormonal levels change over the course of a few years before the last menstrual period, but the key change linked to the symptoms of the menopause is the acute drop in the estradiol levels. That's the thing that causes the syndrome in particular. So some people ask me whether this phenomenon is only for women or do men go through something similar. The difference is the speed of the drop. The speed of the drop is very, very different. So while in men, testosterone will decline over years and years and years, very, very gradually, so the body has plenty of time to get used to it. In women, there is a very, very acute, very massive drop in these levels. And that is the thing that makes the difference. That big change is what produces all the symptoms. So during this transition, periods may become irregular, and some of the symptoms characteristic of the menopause may surface. In some cases, this transition lasts for a long time, where in others is abrupt, which is when the problems are most likely to occur. And this is part of the normal aging process, and it tends to happen between the ages of 45 and 55. The UK average is 51 years old. So what are the different symptoms that one might experience? So most women will experience some symptoms during the menopause. Some women, few, but they exist, don't experience any symptoms at all, and some experience very severe symptoms that can significantly disrupt their lives. And it's important to avoid over-medicalizing the menopause. That can be a problem. After all, it is a process associated with normal aging. But on the other hand, I'm also worried about people under-medicalizing it, if that makes sense. So in the average case, it's probably worth considering consulting with your GP and discussing whether hormone replacement therapy is right for you. One thing that's important to understand is that the symptoms can be so strong that they may feel in some cases almost the level of a medical emergency, or actually as a medical emergency. So particularly, so those vasomotor symptoms that we're going to talk in a bit can be quite bad. Now, one good thing about them is that they're not in and of themselves dangerous. They are just very disruptive and cause significant trouble. So these vasomotor symptoms. So I've got all the symptoms here, but I will go through them one by one to sort of discuss them, and because they all have interesting things and some advice attached to them. So if we talk about the biggest, the ones that most people come to me and ask me about and complain of, and the ones that cause the majority of the problems are these vasomotor symptoms. So they are the most frequent, and out of them, the most frequent are the night sweats and the hot flushes. I list them together as they are related. They're likely caused by this decreasing level of estrogens, estradiol, as we saw before, during the menopause, and their effect on temperature regulation. There's a temperature regulation system in our brains, and it appears that these hormones play a role in it. That's why during the menstrual cycle, there's a difference in temperature depending on where you are in your cycle. So there is this role of temperature management that these hormones have in this particular center of the brain. So the problem is that as the leading theory at the moment is that this regulatory system, as the levels decline, becomes hypersensitive. And even small fluctuations in body temperature lead to triggering all the mechanisms that we have to get rid of heat, and they're turned on when they shouldn't. So these mechanisms, of course, include sweating, opening up all the little blood vessels in the skin throughout the body. And these hot flushes are characterized by this creeping feeling of intense warmth that quickly spreads throughout the body and face. So some women describe them, oops, sorry, I didn't mean to do that. So some women describe these as feeling like you might be getting into a sunbed, or feeling like you are in a furnace. Is so hot, and the sensation tends to last for several minutes, sometimes even longer than several minutes. So women who experience these night sweats, the other symptoms, describe waking up in the middle of the night covered in sweat, even though the bedroom is cool and they're wearing appropriate night clothes. The amount of sweat is enough to sometimes soak the night clothes through and the bedding through. And there's some, I've got a paper there at the bottom of this slide, because it might be worth your while this is open access, might be worth your while reading it, because it's some in-depth reading about the nature and effects of these symptoms. This is a relatively recent but comprehensive paper that goes through that. As I said, it's open access. Anybody can get it. So is this study done by Rebecca Thurston and Haren Jove? Yeah, it's well worth a read, in my opinion. So big symptom. I do a session on sleep, and if you've attended that session, I'm very passionate about the effects of sleep on health. So the two other symptoms that I just mentioned, or the vasomotor symptoms in general, are related to this problem, the problem of falling asleep. So many women will report having difficulty sleeping, and this is quite a serious problem, as there's a strong link between experiencing these vasomotor symptoms and having problems sleep. All aspects of sleep can be affected. So it can be difficulty getting to sleep, waking up many times in the middle of the night, particularly with these night sweats, and waking up too early without being able to go back to sleep. There's another paper there that I've got on the slides that I've got, again, it's open access. So it looks at insomnia and depression during the menopause, and I think is worth a read. We have also low mood and anxiety. They are also relatively common during the menopause. In some cases, low mood and anxiety seem to present before other menopausal symptoms start. So they can be the harbinger of other symptoms. In other cases, it happens at the same time as the other symptoms. When these symptoms present all at the same time, we believe that the vasomotor symptoms, that the ones with the hot flashes, the night sweats, themselves may be the cause for the mood symptoms. So there's clearly a link between those symptoms and the mood symptoms. We know that both hot flushes and night sweats disrupt sleep, and we know that there's a very strong link between sleep and poor sleep being a risk factor for depression and anxiety. So it's also possible, this is a hypothesis under study at the moment, that the drop in the estrogen levels is directly responsible for the mood changes. The answer is that probably both situations conspire, so I think there's a double whammy going on there. Conspire to make it more likely for women going through the menopause to be affected by low mood or anxiety. Specifically, the risk of anxiety seems to be about 60% greater during the menopause, while the risk of depression goes up much more significantly than that. So it's about 200 to 400 times greater. So it's 2 to 4 times higher than women outside of the menopause. So it's actually dramatically different, the risk during this period of time. Many women also report having problems with memory and concentration during the menopause. This appears to be temporary and is characterized by a difficulty in learning new things, and it might again be related to the sleep disruption issue. This effect seems to disappear after the period of menopause, and this might be linked to mood as well. So sleep and mood seem to be the possible proximate causes of the memory and concentration issue. Vaginal dryness and discomfort during intimacy is also an important symptom and is frequently experienced during the menopause. This one is the one that is perhaps best understood as estrogen levels directly. So there's a very clear link here between estrogen levels and vaginal secretions. So estrogen levels, we know, help maintain the appropriate environment, vaginal environment. And when that drops, then this is a clear consequence of that. So this can lead to increased risk of having water infections, quite importantly. So headaches and joint pain are also seen during the menopause, and women also report having bouts of fast, noticeable heartbeats. Those are called palpitations. That also tends to happen. And these symptoms can start months or years before periods stop, and they can last around 3 to 4 years sometimes after the last period. Some women report having them for a much longer period of time, unfortunately. So that's like a summary of what the most characteristic symptoms that one might experience during the menopause are. So now let's talk about managing these. And I'll try to, I'm going to go through, as I said, through all of the different ways of managing them. So I want to make it clear that women experiencing these symptoms should not assume that they have to endure them. They can be extremely distressing and disrupting, and they can, as I hope I made my case, they can affect all their aspects of health. So it's really worth taking seriously. So the sleep problems by itself will increase the risk of various health conditions. So if the symptoms are troubling, or if the symptoms start before the age of 45, it's definitely a good idea to consult with your GP. So that should not be overlooked. Should not be just chalked up to, oh, is normal aging. So the number one treatment for these symptoms is hormone replacement therapy. It can be an estrogen alone, or an estrogen plus progesterone, depending on the individual case. And this can be given as tablets, gels, patches. It can be applied to the skin, and it can be given in the form of implants as well. Specifically for vaginal dryness, estrogen creams and water-based lubricants and moisturizers can be successful. Now, I do want to say something about this because it's important to avoid perfume soaps, washes or douches, or also creams and lotions that are not appropriate should be avoided, as they could cause infection. So if moisturizers are not clearly marked specifically for vaginal use, they should not be used. And again, consult with your GP if this is, you know, if you're wondering about which is the most appropriate to use here. So non-hormonal treatments, we're going to talk about next. For women that cannot or do not wish to use hormone replacement therapy, there's a specific kind of antidepressant called selective selective serotonin reuptake inhibitors that have shown to be effective specifically in reducing the vasomotor symptoms that I was talking about before. These medications work by increasing the level of a neurotransmitter in the brain called serotonin. This a neurotransmitter is a molecule, is a chemical that the brain cells use to communicate with one another. And these medications that have names like sertraline, paroxetine, fluoxetine, seem to directly be counteracting the reduction in serotonin levels that follows the decline of estrogen in the menopause. So there's a link between the estrogen levels and serotonin levels, and these medications seem to be directly opposing that, and that's why they might be helpful. Well, we do know that they're helpful, and the theory of why they're helpful is probably because of that. So in addition, they can also be helpful in the depression or anxiety that is associated with the menopause. So as an alternative to these antidepressants, we have gabapentin and pregabalin. These medicines were initially created to treat epilepsy, but through their effects on calcium channels, in particular in brain cells, they improve their function, so they're not likely to misfire when trying to regulate body temperature. So the mechanism of action here is different. It's more about this regulatory temperature system is misfiring, and these particular medication makes it less likely that these cells will misfire when trying to regulate body temperature. Clonidine is something that is given normally for blood pressure, and actually stops the hot flushes because it stops this opening up of the small vessels in the skin. So these hot flushes are stopped. That's the mechanism there. So this medication has some undesirable effects, so it's not so commonly used for that reason. But if there's no other options, in some cases when the symptoms are severe, your doctor might consider it. Oxybutynin is something that is normally given for urinary incontinence, and it blocks one of these neurotransmitters that I was talking about before. It's called acetylcholine, and there's 2 good studies showing that it can be effective both in healthy women and also in breast cancer survivor, where breast cancer is where you consider, where you have some reservations about the use of HRT sometimes, depending on the case. So those are the ones that have some evidence, and again, is worth the reason I highlight them is because it might be worth your while. You may not know that apart from hormones, there's other things that can be done, and it may be worth your while to consult with your doctor to see whether any of these strategies might be useful for you. So what are the non-pharmacological treatments? So we've got weight loss. It can be effective for some women as there's a higher risk of having this, the flushes and the night sweats when women have a high body mass index, high BMI, right? So there's other benefits from this, such as the probable improvement of sleep, and improvement in joint pain and stiffness that is also associated with the menopause. So exercise is advisable. There's a 2016 study by Bailey and colleagues that shows that it reduces the severity. I think I've got it down there in your slide. that it reduces the intensity of these, the severity of the hot flushes, and also has demonstrable benefits in pain, in depression, and in sleep. So for that reason, it might be a good non-pharmacological alternative. What about herbal remedies? Again, this is a bit of a mixed bag here. So after an in-depth review, and I've got, again, the reference, it's not in this. Actually, I forgot to include my reference in this particular slide, but I will circulate it if people want to sort of have it. So there's an in-depth review. There's some evidence that isoflavones and purified pollen extract may show some benefits. So isoflavones have properties that make them similar to estrogens. So in those women for whom HRT is not recommended, this might not be an option because they're too similar. So basically, if you're not going to use estrogen, it might not be a good idea to use the isoflavones because they might have the same exact contraindications. So there's some evidence for black cohosh. The important thing to remember about these remedies is that currently there isn't good enough evidence to recommend any of them, really. This is because the research is patchy, the products are not regulated, so it's very hard to know exactly what is even in the specific remedy that you bought in the shop. So, what is in it? You might be told that there's purified pollen extract, but because it's not regulated, you might not be getting that. You might be getting all kinds of things. So that's the problem. And also, as I said, the evidence base is a bit shaky. So these remedies can interfere with some medicines as well, and they all have their own side effects. For instance, black cohosh has been linked to liver damage. So I've got acupuncture there just to highlight it because it's not shown to be any better than an equivalent placebo. There's a comprehensive review that, again, I'm quite happy to share. And this comprehensive review done in 2013, it shows conclusive evidence that there's no reason at all to use it. I'm talking particularly about acupuncture. So now, what about psychological interventions? So there's a comprehensive review published in 2017 by Eugenia Stephanopoulos and Elizabeth Grunfeld, and they explore a range of mind-body interventions to deal with the vasomotor symptoms of the menopause. They found that yoga did not have any specific benefits over any other form of exercise, but that doesn't mean that it doesn't have benefits. It has as good benefits as exercise, and we saw how exercise is probably the #1 non-pharmacological treatment that we can recommend, that is also absolutely safe. Similarly, reflexology appeared not to improve symptoms over similar placebos. So there we go. Yoga is as good as exercise, and reflexology was not good. Now, what are the things that can work here? Sorry. So what about, for example, these interventions, these psychological interventions here? So applied relaxation is a particular form of training that we have actually in the Thrive app, was shown to be beneficial for both hot flushes and the night sweats. It reduces the frequency and severity of the vasomotor episodes as a whole, and the effect on severity was sustained at follow-up, which suggests that retraining might be helpful with also keeping the frequency of the hot flushes under control. Mindfulness and mindfulness-based stress reduction was also effective to control the severity of the episodes, but not their frequency. The effects were not maintained at 3 months follow-up. So again, regular practice and retraining might be useful. So it's more about thinking about this as a lifestyle, that you're going to do these things longer term. So we also include, obviously, these mindfulness-based types of exercise in the Thrive app as well. Hypnosis, visualization, and related techniques seem also to have a beneficial effect during training and after follow-up. And this is, again, another technique that we do include in the Thrive app under the label self-suggestion. So in the app, there's a session called self-suggestion. It includes these techniques, this visualization and self-hypnosis type technique. So these three also have the advantage that are all of them helpful, particularly in anxiety and also with sleep problems. So, and also they're safe. So we're not going to get any particularly severe or serious side effects from these. Oops, sorry. So what about the next bit, which is cognitive behavioral therapy? So cognitive behavioral therapy has shown very good reduction in symptoms during the training. This was sustained at 12 weeks after the training and also 6 months after the training. The other advantage is that this technique can be applied to depression and anxiety and also sleeping problems. So we have a transdiagnostic CBT course in the Thrive app. We don't have a specific one for the menopause at this point in time, but is one that I'm intending to incorporate over the next 6 months or so, specifically a module over and above the core module that we have, over and above speaking specifically about the menopause. So that's kind of an overview of everything more or less that I wanted to say. So now I want to sort of go and do a little bit of a recap. These are my kind of takeaway messages, really, and then we'll open up for questions. So the menopause can present itself in many different forms to different women. Some women experience severe symptoms that interfere with their daily lives, whilst others only have mild manifestations. But it is important to seek help and not to endure these symptoms unnecessarily. I think if you take nothing else away, I'd like you to take that away today. And I would recommend that the threshold for consultation should be quite low. There are many available treatments, but the first choice remains a hormone replacement therapy, unless there's a reason why it might be contraindicated. How do you discover whether it's contraindicated? That requires a consultation with your GP. So there are a number of, I will also say one thing, for the majority of women, there's no contraindication. The majority of women are perfectly eligible to have the hormone replacement therapy. There are a number of non-hormonal treatments, including the SSRIs that I was talking about, the selective serotonin reuptake inhibitors, and they have names like paroxetine, sertraline, fluoxetine, those kind of medications. And we saw the specific effect. They probably carry, so there's other medications that can be useful, as we saw, but they are probably the ones to be thinking of. Weight loss and exercise have substantial health benefits in general, and they have proven specific effects with the menopause. And you might use them on their own or also as part of a general strategy to manage these symptoms. And some herbal remedies might be helpful, but they are unreliable in that, because they're not regulated, you might get anything and everything. They can have side effects and they can interfere with other tablets, and they may not be safe. Alternative remedies like acupuncture and reflexology have no evidence that are helpful. And certain forms of relaxation, as we saw, are quite effective, as is CBT. So there's a book there. There's a book recommendation. This is one of the best books on the topic. It's a recent book. It's called Estrogen Matters. It's published in 2018. It's an overview of the effects of the menopause on health and the literature around hormone replacement therapy and its potential risks and benefits. The book is by Avram Blooming, who is an oncologist, and Carol Tavris, who is a social psychologist, and is written for a general audience. And I mean, again, I believe it's well worth your time taking a look at that one, if you want. And with that, we shall open for some questions.
Yeah, we have a couple of questions here. So the first one is, I'm actively going through the menopause, but why do I have symptoms when I'm Why do I not have symptoms when I'm abroad in a hot country? Is there any evidence of why this happens?
Well, it's always very hard to talk about a specific case. So we can speculate. I might be getting it completely wrong because to be able to sort of give you a real answer, we would need to sort of go back and forth, and I should ask you some detailed questions about why this is happening and what's going on. But I mean, my first thinking, the first hypothesis that I might form in my mind is that, as I said, this is all to do with the regulation of temperature. So in a hot country, when the weather is quite hot, it is perfectly reasonable for your body to be trying to shed excessive heat. So it's actually doing it when it should. So it gets inappropriately triggered when you're in a cold space, because it perceives, it's got this difficulty perceiving this external temperature, and these heat dumping mechanisms get triggered, the hot flushes, the sweating, everything else, for no reason at all. Whereas when you're in a hot country, the ambient temperature is so high that it's appropriate for your body to be trying to shed the temperature. So therefore, those responses are appropriate, and they don't cause the discomfort because they are in keeping with what the body's trying to do. That would be my first thought. But again, as I said, it's quite hard to sort of say. Yeah.
Does HRT cause weight gain?
Not necessarily. And again, so it's the question is, so if it's well, if you have the right dose, is well prescribed and is well monitored, it should be pretty much equivalent to the amount of estrogen that you may naturally produce. So from that point of view, when it's well suited to your particular needs, it should not cause any problems like that. It may have some side effects, and there's some cautious with it, and that's why it requires to be prescribed and given under medical supervision. But in principle, there is no reason why the appropriate dose is going to cause a problem like that. Yeah.
Somebody asked to clarify, what is perimenopause?
Perimenopause, yes, is what I was talking about before. So before that huge drop that occurs in estradiol levels in particular, you may have other symptoms, perhaps less severe. You may have intermittent periods, so that they haven't fully, the menstrual cycle has not fully stopped yet. So you have some of those symptoms. So periods might be delayed or absent a few times, but then you have another period. So is that phase during which there is those changes in those hormones, but you haven't yet had perhaps the big drop in estradiol levels, which gives you the onset of the menopause. So it's those symptoms that occur when periods are becoming irregular, but they haven't fully stopped yet. That is the time. That is the perimenopause. Yeah.
So how long do symptoms of menopause typically last? Years or months?
Yeah, no. So I had before sort of an answer to that. I think is when I was talking about the symptoms early on. The process varies widely from women to women. In some cases, they last for a few months, to actually much longer. So so there's this transition period, and you might consider that you can have some symptoms during this perimenopausal period, and that can be quite long lasting. In some cases, then there might be like 2-3 years after you have stopped having any symptoms, stop having any periods, that you might continue to have symptoms. So yeah, so they can be very short-lived for some women. For some women, they can last actually years, actually, after your last period has stopped. So yeah, so it's very different from person to person to person. Yeah.
There are several questions related to HRT. So one of
Yes.
them is asking what are the risks and if it's related to cancer with prolonged use.
Yeah, no, I mean, the cancer risk is one of the considerations, is one of the potential issues that your doctor is going to sort of think about. In the majority of people, that risk is very, very low, and is not a reason to stop it. In some women that have particular personal characteristics, it might be higher, and it might be worth taking into consideration. The thing about it is that it's been blown out of proportion in general. And also there's risks that come with the drop in hormonal levels. There's other risks that come that don't really get talked about all that much. For example, we know that your risk of having heart disease before the menopause compared to men is much, much lower. But when with the onset of the menopause and the reduction in those in estrogens, then that risk tends to sort of go higher and higher to become almost equivalent to that of men. So there we go. So there's risks of not having HRT as well, if you want to think about that. So yeah, the risks are usually, the risks associated with HRT are usually in particular forms of cancer that responds to hormones. But this is not for the average person. This is only for people who actually have those risk factors. So it doesn't mean that everybody who goes on HRT has an increased risk of cancer as a result of it. That's kind of the message. Quite the opposite. It's only specific individuals that may have an increased risk because of their particular characteristics rather than the average person. So no, it's not related to cancer after prolonged use. It's more about your individual risks, your individual makeup. So that's why it's worth definitely a consultation with a GP and to go down in detail. I think that literature, or that sort of, there was this big study, the women's study in the US, which actually kind of sensationalized the risk of cancer, I suppose, in HRT. And somehow in the culture, there's this perception that HRT is got this disproportionate risk for all women, and it's not true. It's only specific women that may have an increased risk. So it's a case by case basis, rather than HRT always will increase the risk of cancer. If that makes sense. Yeah.
Yes, and related to this, somebody said, as this is a natural process, should we not just try to go through it without any medical assistance like HRT?
I think it's a personal choice, and I think it can change from person to person. As I said, some people have a very mild transition and hardly any symptoms, and they feel they can cope with them okay. In that case, I think it's quite reasonable to try, if they so wish. It's quite reasonable not to use any medication and just let it be. But in some women, that is not the case at all. And for example, if you ask me, I think if it's disrupting your sleep, if it's giving you pain, if it's affecting your function, if you're not concentrating very well, if it's really causing you misery, if it's increasing, if it's increasing your risk of depression and anxiety specifically in your case, and we saw how that happens. So the risk of depression and anxiety is probably linked to severe vasomotor symptoms. It's probably linked to disrupted sleep. So that's kind of the vicious cycle. So if that is going on, you have other health risks associated with that picture that I don't think you should ignore. So I think it makes sense that you would seek help. So again, I think each individual should make their own choice about this, depending on how the symptoms are presenting in their case, how severe they are, and in particular whether it's affecting their quality of life. And I would see sleep as a particularly highly sensitive indicator that we should not ignore. If you're not sleeping very well, I would definitely try to do something about that. I would leave it up to the individual person, but that would be my thinking. Yeah.
Is there any evidence that consuming refined sugar can increase the symptoms of menopause, for example, hot sweats?
Not that I'm aware of, but we know that consuming refined sugar has other health risks. Not the least, it will cause insulin peaks, which have their own issues. And of course, it increases your risk of having a high BMI, really, and also having increased insulin resistance, and might pave the way for the development of diabetes. So in general, it's a good health, a good thing to avoid refined sugars, always and in all cases, in terms of your health in general. And of course, it's bound to have an effect, particularly if it has an effect on your weight. It's likely to have an effect here as well. So that would be my answer. My answer is that restricting the consumption of refined sugar is always a good idea in almost all health scenarios. Yeah.
There's several questions about pre-existing mental health conditions. So for women with pre-existing chronic mental health conditions, what is the likelihood that these will worsen during menopause?
Yeah, so that is a very good question in that, yes, I mean, your risk is increased, your lifetime risk is increased. So over your baseline, we see those increases, and they are linked to the severity of those symptoms. So how do we do that if we have a chronic mental health problem? I think in that particular case, your threshold for seeking help and thinking about menopause in its own right, and considering either hormonal or non-hormonal treatments might even be more important to make sure that those vasomotor symptoms are not causing a big issue for you. So yes, it does increase the risk, unfortunately, your baseline risk. And my thinking there would be that needs to be taken into account by the person that is looking after you, your doctor. If you have a psychiatrist, then they should be thinking very carefully about that and the risks there, or your GP in turn. What is the best thing to do here, bearing in mind that the risk is increased? Definitely, yes. Yeah.
Would you still experience symptoms when taking birth control?
It depends. So there's very different kinds of birth control pills. The doses are very different. So I mean, the birth control pill is not HRT, because the difference in doses is dramatic. So it would not be adequate. It would be more about having a consultation and establishing what the best medication to take is for you, rather than assuming that the pill is going to be enough. No, I think it requires a specific consultation, and the doses, as I say, are very different, because what the pill is trying to do is change the proportions of the hormones that already exist, that are there, by a certain amount to achieve a certain result. Okay, so the doses that you're using are very, very different from trying to completely replace the lack of estradiol. That's the difference. So that's why it's not going to be adequate. You need a specific consultation to see what is the right medication and what is the right dose.
Is there any natural foods that contain estrogen that can be used to reduce menopause symptoms?
No, so not really estrogen. I mean, unless you mean, so I don't know. So you might say that some animals, their flesh does contain estrogens, but I'm not sure that is what the question is getting at. No, there's the whole thing about isoflavones that I was talking about before. They are the molecular structure of isoflavones is similar to that of estrogens, and therefore may mimic their effects. And in studies, it seems to sort of do that. Now, the problem is, again, one of those, and what is the right amount, and can we control it? And, is it purified? How are we sure that what we're taking is exactly the right dose every time? and is consistent. So I wouldn't rely on that, even though, yeah, these isoflavones do exist and that they come from quote unquote natural sources. I mean, estrogens are natural in themselves. So yes, there is that. But in order to be able to actually target the symptoms appropriately, it does require to be sure that you're always having a consistent dose, and that is very hard to ensure in that way. Yeah.
There's again some questions about HRT, and there's some questions which ask for how many months or years is HRT taken for? Like how long can it be taken for?
Again, it changes from person to person, and it requires individual consultation. So as I said, in some cases, these symptoms are reduced and disappear fairly promptly, and in some cases they may last years. So depending on your specific case and how severe your particular symptoms are and what the objective of the treatment is, then it might be that you need to take them for years, or it might be that a period of months is enough, or it might be, so it's quite hard to answer because it is very, very individual, and it requires that consultation, and there might be some circumstances in which you're deciding, okay, so we've been on it for this long, the symptoms are relatively well controlled, we may sort of try and reduce it. What are we going to do exactly to sort of manage the situation? So very hard to give like a hard and fast rule for this, because the phenomenon itself is so variable, from almost no symptoms in some individuals to extreme, quite severe, very disruptive symptoms in others, from a relatively short duration in some individuals, maybe a few years, to a much longer time. So after the last period, 2, 3, 4 years, or sometimes even longer. So it is very much, and so there's a range of duration and a range of severity there that would bear individual discussion. So I wouldn't assume any duration. It should be more led by your particular risk and benefit analysis. And so how severe your symptoms are, how long is the duration, how much do they affect you? Those kind of things, have a bearing in that consultation. So I wouldn't be able to sort of say this many months and that's the answer. No, I think it is about individual consultation with your physician. Yes.
Mm-hmm. Do periods return when taking HRT?
They might do. They might do. Yes. Yeah. Depending on how it's done, they might do. Yes.
Do any of the symptoms experienced during menopause continue when you are post-menopause?
Sorry, do any of the symptoms
that you experience when you're during menopause, do they continue post-menopause as well?
Yeah, so there's a period after the menopause. It depends on what we're talking about. So if we're talking about the last period, yeah, yeah. So there's a duration after the last period. And many women experience it for months, years, as we said before. If the question is if the symptoms have subsided and disappeared, do they come back again? The answer is no. Once you've gone through that period, it resolves and the symptoms don't come back again after that. Yeah.
Is it normal to have low or non-existent libido?
Yes, that can happen. Definitely. Yeah. Yes. Yeah. And again, the other thing is because you have very many women will experience vaginal dryness, that makes it even harder because it can be painful. So sexual intercourse can be painful as well. So it's going to be very hard to conjure up any libido under those circumstances. So yes, it is actually something that happens. Yes, definitely. Yeah. Again, best consultation. Yeah.
I'm on one utrogestan tablet and one estradiol gel pump twice a day. Sleep has improved, but not really. Would testosterone help?
No, I mean, it's hard to say. So I think whoever is prescribing your regime you need to have a consultation with them and see what needs to be done. Is the dose correct? Are those the right agents? Are the right dose for you? Yeah, I mean, it may be that it needs to be supplemented with testosterone or not, but it's something so specific that it needs to be done on a one-to-one consultation with your doctor that knows your case specifically. So I can't really comment on that. No.
Somebody asked, how quickly will HRT work?
Well, it tends to, if it's going to work, it tends to work very quickly. Yes, yeah. So very soon after start taking it, the symptoms should change. You may have to go through a period of adaptation to figure out what the right dose is and what the right regime is for you. So we saw that question where they had a gel and a tablet and a combination of things. So it depends on when your physician is able to find the exact right combination dose for you and what sort of specific agents they're going to use. But after that is done, it works fairly quickly. Yeah. To resolve quickly after the right dose is found. Yeah.
Somebody asked, how long would menopause take after having a hysterectomy, ovaries inact?
Yeah, so with the ovaries as well.
Yeah.
That's the thing. So the onset of the menopause there is caused by the lack of the ovaries. So the ovaries are gone. The ovaries are where the estradiol is produced.
Oh, so, no, ovaries inact. So I think that they're still there.
The ovaries are intact.
Inact.
Okay. Sorry.
Inact. Maybe they meant intact.
Okay.
Yeah. Intact.
All right. So if the ovaries are in place, then the fact that you had an hysterectomy does not change anything about the menopause. So you're not going to have it until such time as you have it. It sounds like a very strange way of putting it, but the uterus in itself is not going to be producing any hormones. So the hormones are produced within the ovaries, and therefore, if the ovaries are intact, they're going to produce what of estrogens they're going to produce. So the problem is when the ovaries are removed as well, as part of the procedure, then it leads to a very acute drop, obviously, from whatever level you had to nothing immediately, and that causes quite an abrupt onset of the menopause symptoms, and can be some of the most severe presentations, because it's not like, so in the average case the drop can be quite profound and rapid. In this case is as acute as one can imagine, so it's much more likely to result in unpleasant, quite difficult, quite severe symptoms. In that case, actually, the other thing is that obviously because you have no uterus, the risks of HRT are different, and the regimes that you use are different, because you don't have to account for the presence of the uterus when you are giving HRT, which sometimes you have to when the uterus is present. So it's a good scenario for considering HRT, because the symptoms are going to be severe, and some of the particular concerns that you may have with HRT will not be present if the uterus is not present. Some of them, not all. Yeah.
So a couple of people have asked, what is the danger of taking HRT if a family member has suffered from cancer?
Yeah, so good question. And again, it requires individual examination. So it's a case, you're right to think of it and you're right to flag it up. I would not discount it though. It depends on what the cancer was and how it came about, and whether it's a hormone sensitive form of cancer or not, whether there is you know, there is a genetic component that can be detected and can be traced or not. So I would not assume that it's contraindicated, is what I would say, but it's definitely a good question to ask, or whether it might be contraindicated. Obviously, the chances of it being contraindicated are higher than if you don't have that history, but it's not necessarily true that in all cases it's going to be contraindicated. So I would not dismiss it. I would do the consultation and make sure that it's all understood before, concluding that it's not for me. So it probably will not. It will be beyond the scope of your GP. It might bear consultation with either an oncologist or a gynecologist that is experienced with this. But that's no reason not to ask. Yeah.
Somebody asked, at what point would you encourage women to seek help of a referral to a gynecologist?
Yeah, no. So I think again, your GP might be more or less comfortable with this. I think having an open discussion with the GP is valuable, and seeing where their expertise lies, and if the GP is comfortable and has done an initial consultation and you've talked through the possibilities, and maybe they've started some treatment, but that treatment is not doing what it should, then it's probably a good idea to consult with a gynecologist. So at that stage, I might prompt my GP to say, look, we've tried these things. It seems that my particular case is not responding to this particular approach. It might be time to consult with a specialist. So, I mean, my threshold would be relatively low, unless the GP has a special interest, then it clearly is experienced in doing this. Some GPs are very good at this. Some GPs do gynecology as an elective, and they know about this a lot, even more than I. So therefore that would be perfectly fine. So I think it depends on the individual GP and their own degree. I think hopefully you can have an open conversation with them about their own degree of confidence in the management of this, and whether it's appropriate for a specialist to intervene. But I would say, if they want to go ahead, if you have an initial consultation and you're doing a care plan and it's not working as expected, it might be a good time to consult with a specialist.
Mm-hmm. I'm just conscious of time. Are you okay with going over time, because there's more questions?
I think, should we take 3 more?
Okay.
And yeah.
Somebody asked if you have any recommendations for UTIs. This person has never really had them before, but is having them now since starting HRT. Since starting
HRT? Mm-hmm. So the HRT has come coupled with the UTIs. It may be correlation, may not be causation in this case. So it may be that it is related, or it may be that it's not, that is something else going on. So if I have repeated water infections, what I would like to know is whether there's something else going on in particular, because there might be something that coincidentally happened at the same time. So I think it's a good time to go for not assume that it's the HRT, and go for a wide look at it, and have a discussion with the GP about what else could it be, that is prompting this repeated UTIs. Is it, well, is that your alarm going off? So Elisa's alarm is going off. So is whether there's something else going on. That would be my first number 1 question that warrants. So should we take a broad view of these UTIs and try to get to the bottom of them? In principle, there's no real reason why they should be linked to the HRT. So I think it's an issue. Yeah. So it may require a consultation with a urologist, or there is, I think I would take a broad view of it and try to get to the bottom of those UTIs without assuming that it's the HRT. That's what my feeling would be.
Mm-hmm. Can the changes in hormone levels also impact thyroid function?
Sorry?
Can the changes in hormone levels also impact thyroid function?
Thyroid function, not directly, no. No, I mean, thyroid function should be independent of this. Again, it might coincide in time. As we age, is more likely that we may start having low thyroid function for other reasons, perhaps related. So the common factor might be advancing age, but they're not necessarily linked to one another, other than through age being in the middle. So no, not necessarily. Yeah.
Mm-hmm. All right, so one more question.
I've got something here that somebody says, I think it might be worth mentioning, increasing facial hair, which was not a medical issue and can be psychologically challenging. I myself wasn't prepared for that aspect. Absolutely, yeah, no, I should have, and that is true. Yes. So you know, thank you for prompting me to mention it. It can be quite challenging psychologically, and also it gets to your identity. So it's actually is not trivial at all. It's something that can be quite threatening to one's identity directly. So that's why, yeah. So that's why it's worth mentioning. So thank you for the prompt. Definitely, yes.
Would you like to answer another one?
Yeah. Should we do one more? And
okay. Is there a hormone level test that can be carried out by a GP to determine if you're going through menopause?
Symptoms are your best guide, really. Yes, the answer is that you can do a determination of all these hormones, but doing that determination is of limited clinical use. You don't. I think you're best being guided by the symptomatology that you're experiencing, and then by doing a titration of the medication appropriately to control it, other than going down the hormone level route. Hormone level is useful in a research setting, but not necessarily in a clinical setting. So yes, it is possible, but unless they have good reason to do it, they're not going to do it. Yeah.
Mm-hmm. Well, I think that was all for today, just because of the timing. There's many more questions which we couldn't go through this time, but maybe we can have another session some other day.
We can do another session, absolutely. But yeah, thank you all very much for all your questions. I think that was it was very good for me to sort of lead the discussion, and thank you very much all for listening. Yeah.
Thank you, everyone. Bye.